Hi, my name is Jason Spangler, the CEO of the Innovation and Value Initiative. During the 5th annual IVI Method Summit, we explored patient-centered health technology assessment, or HTA, and charted its future course through discussions, methodologies, and networking with thought leaders. We aim to offer actionable steps for stakeholders to implement patient-centered HTA effectively. The 5th annual IVI Method Summit panel presentation, titled Putting Equity into Practice, Patient-Centered Methodologies and Frameworks. Building from IVI's recent health equity reports, this session will highlight practical examples of how patients and researchers can partner to incorporate health equity into HTA and explore the research questions that need to come next. This features as moderator Elisa Halpern-Paul from Venable, with the speakers being Sneha Dave from Generation Patient, Anton Avesenya from the University of Texas at Austin College of Pharmacy, and Belinda King Kalamanis from Longevity Foundation.
Sneha Dave is the founder and executive director of Generation Patient. Dr. Anton Avesenya is an assistant professor of health outcomes at the University of Texas at Austin College of Pharmacy. And Belinda King Kalamanis is Dr. Belinda King Kalamanis is senior director of patient-focused research at the Longevity Foundation. Please come to the stage. And as they're taking their seats and grabbing their microphones, I wanted just to call out and lift up that IVI has a significant and impressive body of work on equity. In particular, I wanted to do a little show and tell this morning. If you have not already availed yourself, please, again, at the QR code, make sure that you see this report, which is Fulfilling the Promise of Equity and Value-Based Care, a focus on power, people, and processes in health technology assessment. It is an incredible summary. It came out in September of 2023, reflecting the amazing work that IVI has done on equity, which is our topic for this next session. And thank you for those of you in the room who are getting your caffeine and your hydration. For those of you online, stick with us. We're going to plow through this morning and jump into the conversation of health equity. Good morning. Great to have you here. Before we jump into the prepared questions, like we did with the first discussion, I would like each of you just to give a brief introduction of who you are, what brings you to the conversation today about patient-centered health technology assessment, and a little bit about your day job, just so everyone can understand the context and the perspective that you're bringing forward. So we'll start with you, Anton, and then Belinda, and then Sneha.
Thank you. Good morning, everyone. Thanks for having me here, IVI. So I'm Anton. I'm a faculty member at UT Austin. So my day job is, I trained as a modeler like Mel, so I conduct cost-effectiveness analyses and economic evaluation, also do some real-world evidence generation, mostly in mental and behavioral health treatments. But I also, as a faculty member, train the next generation of HUR professionals who are doing this type of work in pharmaceutical companies and nonprofit organizations and government. So happy to be here.
Great, thank you. Belinda.
No? Yep, there we go. So I'm Belinda. I'm the Senior Director of Patient-Focused Research at Longevity Foundation, which is a lung cancer patient advocacy group. I'm a psychometrician by training, but have had a few different hats over the past few years. Before joining Longevity, I was at the FDA in the Oncology Center of Excellence. Before that, I was a consultant to industry, and before that, I was in academia. So today I will be pulling from those different experiences and some of the work we've been doing more at Longevity, though, to discuss this topic.
Thank you. Sneha.
Hi, everyone. I'm Sneha Dave. I am the executive director at Generation Patient. Generation Patient is an entirely young adult patient-led nonprofit representing adolescents and young adults with all different chronic and rare conditions, so everything from lupus, Lyme, arthritis, Turner syndrome, hemophilia. We have a wide range of young adult patients represented in our community. I am also a young adult patient. I was diagnosed with ulcerative colitis when I was a little under 6 years old, had the colectomy surgery, which is the removal of my large intestine. So I've had a pretty significant experience and have really grown up within the confines of the medical system. A lot of what we do at Generation Patient is focused on peer support. So we're thinking about peer support as an intervention in our community. We actually have an award through PCORI to do this. And so we're really trying to systematically look at this area. We focus on higher ed accessibility. And then our third area is in health policy. And we have 3 areas of health policy that we focus on, which I won't talk about here. But one of the things that is important to us is that we are independent of all private healthcare industry funding. So that includes insurers, PBMs, pharma, hospitals. So everything that we do is truly authentically driven by our community. I got involved in HTA actually through an internship at Pfizer, which is sponsoring this event. So it's really full circle. I interned in health economics a couple years ago, well, I think about 3 years ago now when I was in college. And it was really cool because I got to be exposed to this field from the economic side, but also understand the importance of HTA, especially internationally. And then I've since done some pediatric HTA work with the MRCT Center at Brigham and Women's. And am super excited because I get to serve on the Midwest CPAC for ICER as a patient, and I've done so for the last 2 years, and that has been just a phenomenal learning experience, and I think there's a lot more room for patient voices there. So that was long, sorry. Thank you.
That was terrific. And I think I speak for everyone who's my age or older in the room, like, way to go. Like, so great. Wonderful to have you here. Before we jump into the prepared questions, I'm going to use the moderator's prerogative here and just ask each of you to reflect on what you just heard from Christine and Mel and see if there's something that really has risen to the top of your mind or something that maybe you're going to now do differently or take back just based on hearing their conversation. So Sneha, we'll start with you.
I loved the last panel actually. And actually Christine is a friend and I haven't seen her in the last couple of years, so I was really excited. And then Mel I've gotten to interact with Ricer. So anyway, so I think that what really struck me was the population health level comment, because as I was thinking about this, and Mel, you mentioned something about like what matters to patients and transportation and everything like that. I was reflecting on my own experience and I realized that there are so many different considerations when we think about what matters to patients and even from an age basis. So for example, some people might think that like an infusion or having to go to the hospital like once per month is worse than like having to take pills every day or something like that. And I think from a compliance perspective, I am not known to be the most compliant patient. I've tried really hard, but so like for me, having a once per month infusion is so much better than having to take pills every day. And I think that differs like based on age, whatever that might look like. So I think like the population health level approach and like that framing of thinking is really important. And I think it is like critical to think about. So I appreciated that.
I appreciate you lifting up patient preference as a really important component here, because it's not just about the direct impact of the therapy itself, but it's also how somebody's lived experience or lifestyle and their preferences. So that's great. Thank you. Belinda.
Thank you. Yeah, similarly, I was thinking about the group level versus individual, and it is a real challenge, I think, that we face because clinical trials, health technology assessments do really focus on population level. And then, when clinicians are sitting with their patient making a treatment decision, you have that individual. And so does the group data relate to the person? And this is just a struggle that we have not worked out yet. And just thinking about our own programs at Longevity, it's often one directional. The information is coming from researchers to patients, or we invite them in very limited ways, but really we have to expand these conversations out to sort of make sure the data that we're collecting can trickle all the way through down to treatment decision making.
Great, thank you. Anton.
So that piece also resonated with me. I think the struggle between balancing population and patient level outcomes. The one other piece or theme that came up for me was communication. It seems like there might just be a need for more of these forums where we're really talking about, again, speaking from a modeler's point of view, I think if it's done well and thoughtfully, models can reflect a lot of the patient level considerations. And if again, if we do it correctly, the parts and pieces of an economic model should have been informed by patients, and the decisions we're making to omit or include things should have been informed by, or are typically informed by the evidence. So I think it's just a matter of communicating why decisions were made in some ways. But of course, communication also involves kind of, the timing of the communication is also important. So this idea of involving all the stakeholders at the beginning seems to be like a low-hanging fruit and a good approach to make things.
That's great. Thank you for helping pull through. So this panel's title is New Methodologies and Frameworks to Incorporate Equity into Health Technology Assessment. So we'll go to the planned programming now. So a question for each of you, which is, as we said at the outset, there's been a lot of discussion about how do we address and incorporate equity into health technology assessment. When we had our summit last year, we talked a lot about if there's no equity, there is no value, right? That's kind of a base, thesis, if you will, or a premise is if we don't have equity, how valuable can anything really be? We also know that there's a pretty significant data gap. Mel and Christine alluded to that. And there's some examples where we've been able to kind of bridge that gap. But let's talk a little bit first about what's standing in the way. What are the barriers? What are the challenges that we have to overcome with respect to the data gaps in incorporating or addressing health equity and health technology assessment? So Anton, I'll start with you, especially since you're working with the next generation on this, and then Belinda and Sneha.
Yeah, I think for a while there were serious issues around measurement. So what are the actual questions and tools that we would actually use and deploy in surveys or electronic medical records or claims information that would make the measurement of these different equity relevant information usable and actionable. But I think we've moved beyond that, and there's a lot of scholarship that deals with this type of work. So I think it's a matter of changing the culture and the incentive structure to really advance the collection of these equity relevant data. I'm thinking about, for example, I think Belinda, you pointed out that, the FDA guidance on collection of race, ethnicity data in trials, the guidance I think came out in January this year, or the draft guidance, and they lay out the specific categories of race and ethnicity that you might include. I personally don't think that goes far enough in the collection of race and ethnicity data. There's better work happening in the Census Bureau, if I share my opinion about this, that really asks about ancestry and heritage and that kind of stuff, and I think that helps us get to the real issues around racial and ethnic differences in terms of treatment effectiveness. So that's I think the two issues that I'm thinking about: so measurement and then kind of the incentives that we're under right now in collecting this type of information.
Great, thank you, Belinda.
Yeah, I think that leads into what I was going to say to Anton perfectly, which is, at clinical trials, the remit for that data, which then gets fed in often to HTAs, is safe and effective drugs, right? So you have this tension then between speed. We often hear at the advocacy level, we want it now, sooner, faster. But doing really good community building and outreach is not a quick process. It takes time to build trust and relationships with populations that are less visible. And that creates a tension. And so I think with the clinical trial data, the FDA has its diversity plans for pharmaceutical companies, but that's just one small step to sort of looking at this from a health equity point of view. Diversity is not necessarily going to get you equity. Clinical trials Most of them in oncology, at least, you're talking about US participation at around 10% or so. So these are actually really global, and what's relevant for equity in the US will not be relevant for equity in Russia or China or other countries where trials are being conducted. And so even if we do get these plans implemented, we're talking also that data won't be available for 4 to 5 years, and people want this now, not in 4 or 5 years. And so while I am trained as a statistician, I do think there's a lot of room for mixed methods in doing this work, and there are examples of inviting patients to participate, but I think we can do that more systematically and in structured ways. And as well, people often point to real world data, but we don't have any patient experience data, or you have to do a supplement study to get at patient and caregiver experience. Forget caregiver, like we don't even have structured the patient experience data. And coming from EHRs, they may have collected a little bit of that, but it's so haphazardly done that it's not necessarily the best for doing a data analysis with. And I like that Mel was talking about some of the separate studies that could be implemented as well to gather some of that information and then connecting with folks to then be able to make sure that you've got the right variables, because it's not just having data. Like I've heard people say things like, oh, well, the data is the data and we can, yeah, kind of, maybe. It has to work with the model and be what we expect and in a way that is relevant. And then the other thing that I'll just mention before giving Sarah an opportunity is, value when, right? Some of the work we've done looking at preferences in treatment at longevity is that we see some differences in timing of when we ask people who are on their first treatment to later treatments, we see preferences changing actually. And it's not really static one-time assessment of what people value.
That's a great point, Sneha.
Yeah, so I think when we talk about health equity, we think about race and ethnicity, which is really critical, but we also have to think about age. And I say this as a former pediatric patient, and even for young adults, I think like we've often subgrouped like 18 to 64 or whatever that looks like. And an 18-year-old is different than a 64-year-old, has different needs, whether that could be physiologically depending on the condition, but also socially, emotionally, system-wide. So I think that's an issue, but I also think like in the European context with the pediatric regulation, with the PIP improvement, like there's just so much exciting things happening there that I think we could potentially, hopefully adapt to in the United States. I'm not sure how, that's definitely not my area of expertise, but I also think that we really need to think about pediatrics as a special population as Europe has done, and older adults that falls into the same category as well. I think it's really tricky though too with conditions that are not like specific to pediatrics, but impact adults and kids, and what extrapolation could look like. I think one of the concerns that I have about extrapolation is that when we're doing that, do we have adequate long-term safety data repositories that we're tracking? And sometimes it doesn't feel like we're doing that appropriately or as diligently as we need to. And so I think that is part of the issue. And the second thing I was going to mention, I was just thinking about this while you were talking, Belinda. Nothing that you said made me think about this, but just came in my head, is that I did a panel at ISPOR last year about transparency in HTA. It was focused on like the importance of having more data. And I think, one of the issues that I saw while I was doing that panel in preparation was the amount of information that's often redacted. I think that's really scary as a patient. There's some adverse events data that's redacted. And patients absolutely need access to that, whether that's talking about HTAs or ICERs or, whatever it is, but just from a moral ethical level. So I think that's something that we need to grapple with too, is like, what are we redacting and why are we redacting that data and at what steps? And then when that data is, commercially available or public, then are we going back and making sure that it's accessible to patients and other HTAs and not regulatory agencies, but the broader public. So that's just something that I think about with access to data too.
Those are great points. And I very much appreciate you lifting up that when you're doing an assessment for the pediatric population or young adults, it's materially different than middle-aged folks or people who are on, 65 and older. My pediatrician regular, or my boys pediatrician regular, reminds me they're not just smaller, although they are bigger than me now, but like, small adults, right? There are material differences and different considerations, whether it's physical or mental health issues or developmental. So thank you for reminding us of those important differences. Anton, I wanted to round back with you as you, as I said, are training the next generation, and you're steeped in this work every day. And today is about moving from our talking about things to actually doing this work in a more meaningful and deeper way. How can we boost or kind of accelerate the incorporation of health equity data? So you shared that initially it was, maybe some of the measurements issues, but now that we've kind of solved for some of those problems, and you mentioned culture, and I don't want to dismiss, culture is a big issue, but is there something that can be done, and maybe it's IVI, I heard you say, more convenings like this. So on the worksheet, I'll call out the worksheet again, make sure you're working on your worksheet as we have this conversation. What comes to mind as some things that could really be a shot in the arm here?
Yeah, I have three kind of buckets in mind. So the first is I'm going to call it innovation in research. So, speaking about, imperfect data, there are methods that have been developed to address some of the missingness, for example, around maybe certain variables or identities that we want to capture in data. For example, there's, we've been imputing data for many, many years, but, with the advent of machine learning and AI, there's been some methodologies developed that have been tested to understand how well they might perform imputing some of this missing data, so that this excuse of data not being available.
Microphone in the middle, I think it clicks a little if you hold it down near the bottom. Just hold it in the middle. There you go.
There you go.
Yeah.
I think I need a mic stand.
Yeah.
So innovation is one. Mel touched on some of the innovation in economic evaluation. So this idea of distributional cost effectiveness analysis, I think the first textbook on it got published when I was in grad school. So it hasn't been that long ago, but we do need more examples of how it can be used and what types of evidence it generates that's usable for this now deliberative HTA process. So that's one, innovation in research. From a research point of view, I think the impetus is on us to really test these things and see where it can take us, and just build the literature around this. The second is education and training. I'm just calling this communication now. I think there's obviously some on our end of the things as we're training this next generation of HR professionals, which, by the way, I'm clinging on to myself as a title. We're including health equity as a core component of their competency before they go on to the world.
That's great.
To do this type of work, whether it's on the patient level, measurement of outcomes, or to economic modeling. So that's one. I think there's communication that also needs to happen with the discipline, I think, that's been doing this work for the longest, which is public health. They've been talking about health equity for millennia. And maybe HUR just stumbled upon it recently. But we have colleagues across the aisle who are experts in this, in the measurement, in the how to frame it, how to address it, and all of that. And then finally, again, going back to incentives, I think research funding is a big deal. If you want to do this well, it does take sometimes more resources, and that needs to be coming from the funding that we're pursuing. And then again, I think incentives can come from policy, best practices, guidelines. How do we do this well? What's the threshold that people need to meet before this is used or published? So for example, one thing I personally do now is when I do a cost effectiveness analysis and I don't look at any of the distributional effects, I stay in the discussion. This does not address equity. I say it out loud because I don't want people to think that there's any ambiguity here. And I think more people do that.
That's great. So it's time to open it up for questions from the audience. So I'll turn first to the folks in the room. Questions here for our panelists about health equity and addressing some of the data gaps. Any questions first from the room? Crystal clear. Wow. Okay. Yes, online questions. Thank you. Please, Melanie.
We have a question from Danny Van Leeuwen of Health Hats Online. The conversation has been about independent patient recorded data. What are good dependent variables or outcomes to use when studying equity independent variables? For example, can CMS cost and clinical measures be used as dependent variables?
That's a very technical question. Thank you for that. Does anyone feel like they can tackle that one? Everyone's like looking at each other. Belinda, you want to give it a shot?
So sure. I mean, yeah, I don't know the answer to that question. I haven't thought about it from that perspective, but we do need good data, like good quality data, that is for sure. And it is hard to find. To Anton's point, you can impute, but then of course there's always, just reading something the other day and I'm like, they imputed a lot and there's a lot of assumptions that are underlying what the conclusions are.
For lay people who may not know what you mean by an imputed data, could you just explain that?
Right. So when
Please.
the observation is missing in a variable for somebody, you can use there's different ways to do this, but you can pull based on the current data set another value in and estimate it basically based on someone else, perhaps like them, or if it's longitudinal, you could perhaps use some other methods as well on past data that person has provided.
So it's a legitimate way to fill in the blanks, if you will.
Yes, but
Okay.
there's definitely some assumptions that are made when you do it.
Fair enough. Great. Anyone else want to try to respond to that very excellent technical question? Okay. Yes, we'll get a microphone to you. Wait one moment, please. Thank you.
This is James Class from Gilead Sciences. Interesting reference to artificial intelligence and machine learning. But what it makes me wonder though is like how you look at the risk opportunity here, because at least in my N of 1 experience with AI, the results are not so great, even when it's from very normal stuff in the public domain, like like laws, where you should be able to get straight answers. And there's always, there's lots of, real concerns about reinforcing biases, misperceptions.
Right.
And I think we're all very thoughtful, but, a lot of people are probably just looking for answers right away. So, yeah, how do you see it? Risk, benefit? What should we do?
Great question. Anton, you want to kick us off?
Yeah, no, I totally agree. There are a lot of concerns around all these novel methodologies, and quite frankly, there was a paper that I read recently that showed that our standard practices for multiple imputation, which is based on kind of standard statistics, is actually better performing than some of our ML algorithms and AI. So it's not ready, but I think it's an opportunity again, because I think this is a space for innovation, especially when people claim that the data is not available or it's not complete. So I think it just raises brings attention to this idea that we're not at a dead end, that there's ways we can potentially deal with it, assuming that they work well.
Great. Belinda?
I agree. I absolutely agree.
Okay. Melanie, you have another question from online?
I do. This comes from Suzanne Singer, who's a patient and attorney in New York. Do you have any ideas about how to incorporate information that patients want to offer, but aren't always asked for? For example, when I was in a trial, I was given a sheet of questions to answer at each visit, but nowhere to put feedback I wanted to give, but there was no way to communicate that. I believe getting more nuanced patient feedback and perspectives would be more inclusive and equitable.
Great, thank you. I'm going to ask Sneha, since you work with patients, you are a patient, what your reaction to that is, and any recommendations or thoughts about how we can do a better job at soliciting more information from patients and then having it be actionable.
Yeah, well, I think that's a great question. I think you sort of had an answer in that question already, which I think is awesome. I think one of the things that I was thinking about when you were talking is that there's a big trust issue in like patients disclosing information or feeling comfortable disclosing information. So I think when we go to like an HTA body or a clinical trial site, like you don't just feel like sharing your story. You don't just feel like sharing information that might be really sensitive. And so I think like having, community partners as part of the process, whether that's part of a trial or HT body is really critical. I also think social workers are just really awesome and should be incorporated more within every aspect of the medical system, even in economics. And so I think, they have a unique way of understanding the whole person rather than just, the patients and the symptoms, whatever that looks like. So I think that's a great opportunity is like, how can we incorporate more qualitative feedback through using community partners and community liaisons to have that authentic feedback rather than just like, what we think that a clinical trialist might want to hear or an HTA body might want to hear.
That's great. Thank you. Belinda.
Yeah, I think this is, such an important thing. And it's difficult we haven't done a very good job of it. For example, this meeting is happening on a Thursday during the middle of the day. There's people who can't attend this. And so how do we get their feedback when we're having meetings that they can't attend? And I think we have to stop sort of thinking that people have to come to us and operate on our terms. It's bi-directional, and I think there's a lot of opportunity there. People come to longevity. At longevity, we have on my team, there's 2 PhDs and 2 people with masters in public health. We have an amazing science-based team, but not every patient advocacy group will have that many people who are trained in public health or methods. So when people do outreach to find and elicit that information, thinking about who are you reaching out to, on what terms do they want to engage with you? I think that we just haven't thought that through. We just assume that they're going to come and tell their story. And then often chatting before this meeting about this idea that researchers then don't always do a good job of like prepping folks to have the conversation, because there's some things you just simply cannot do from a methods perspective. And that's okay. We can have those conversations, and it's back to being transparent. Like Anton was saying, that this doesn't include this, or this doesn't have this because of X. And if we say that, I think then, we can all have more open dialogue about what are realistic and pragmatic solutions versus just sitting around having the same conversations over and over.
Owning what it is and what it isn't, and being honest about it, and communicating and managing expectations around it.
Absolutely. Yep.
That's great. I think we have time for one more question. Yes, if we could get a microphone up here. Thank you.
Good morning. Simon Thomas, AstraZeneca Rare Diseases. Thank you for the excellent topic and conversation we've had today. So on the topic of equity, I think it was the last Method Summit where we discussed no equity, no value.
Exactly.
And that is different from equality, and we discussed that as well.
Correct.
So my question here is, when you look at equity, which means a needs-based assessment of the population, if you look at rare diseases, for example, the needs are very different from a more common disorder. So how would you apply, or how do you think about equity from a rare disease space versus a more commonly occurring disease condition?
Thank you, Simon. Sneha, you want to start?
Yeah, I think maybe a little bit more time to answer this question, but I would also just say, like, I just go back a little bit to the age component, because like technically the form of ulcerative colitis I had is rare because it was very early onset pediatric, but we still have like therapeutics, in the pipeline for ulcerative colitis, whereas like adult onset ulcerative colitis is not considered rare. So I don't know how to answer your question, but I think it's very variable based off of the disease and like the range of people it affects too. So
I think that's a great answer. I think you covered it, which is to say part of it depends, right? It depends on the disease, the rare disease. It depends on the population that's affected, and it can't be a monolithic approach, right? On the health equity piece, I'll have Belinda and Anton hop in, and Simon gave you a little bit of a preview of what his panel discussion will be this afternoon. So thank you for that advertisement, Simon. The point that I think Sneha lifted up earlier, and again, which is reminding ourselves that equity is also not just about race and ethnicity, right? It's age, it's geography. My husband grew up in a rural community in Northwest Indiana. I grew up in Silicon Valley, right? He's always reminding me that the lived experience I had in California in the suburbs of Silicon Valley were dramatically different than the access to care issues that he faced in Northwest Indiana. So I also just want to remind us that that when we talk about equity, we have to also remind ourselves that it is a very, we are inclusive in when we think about equity, that it's not just one or two components of race and ethnicity, it's multifactorial. So Belinda and Anton, reflections on what Saimu asked about rare disease.
Yeah, there's a lot of intersectionality. And then when you go to rare disease, how do you unpack it? I think that that is a great question. And there's still methods being hashed out because you get small samples and it's difficult to analyze the data then. I think there's probably room for qualitative methods and then triangulation of data to help understand some of the issues. But, to Sneha's point, it depends then a little bit. I think everyone wants like a recipe that's easy to follow. Like I tick these boxes and I have an answer. But there are going to be differences between different disease conditions and, are they life-threatening or are they chronic as well? And what do the treatments look like? Are they short-term or long-term treatments that play a role in understanding the assessments as well?
Great.
This might be my spiciest contribution to the talk. So I do want to say that I think precision around how we use the terminology is really important. So I think when it comes to rare disease, one of the big health equity issues that gets raised is because the populations are so small, the development of interventions has been little to none. And that's an unjust or unfair reality, right? Because remember, health equity is addressing health disparities, which is unjust, unfair differences that can be reversed and that's socially made. So I think also being clear about what health equity issues we're addressing is very important. And I think that gets to going beyond just race ethnicity because there are many unjust, unfair differences. But I think I also want to push back a little that sometimes I think health equity is being used in ways that it's not meant to be. And reframing everything as a health equity issue, I think also dilutes the true meaning of health equity and our ability to address other health equity issues. Some are issues that we just have to address, like the lack of treatments for rare disease. I think that's an important outcome in of itself. But I encourage everyone to really, yes, because some health equity issues also cannot be addressed by the medical system. So I'd hate for us to medicalize everything.
Right.
So, just throwing that out there.
That's great. Thank you. We have 1 minute, so I'm going to invite you to ask a quick question or make a quick comment. Name and affiliation, please.
So Vicky Bartgut, nice to meet you all with Fiverr Health. One of the things that we do is patient HCP engagement. Everything we do is evidence-based. So for us, when we do the analysis, it's really assessing the pain points of the patient, the pain points of the HCP, and then really going to literature, investigating it. But to really address the equity and all these other things, once it's created, we actually go back to the patient, we actually go back to the physician to really assess, is this understandable? How does this graphic make you feel? Is this word really something that you can understand? And only when you do that can you really address that health equity. Because, does it really, is it adaptable to, your race, your ethnicity, where you're living in the country? And we see actually we create really effective ways based on that additional feedback. So just something to think about.
Great. Thank you for sharing that. I appreciate it. So I'm going to just wrap up with some key themes that I heard. And these are in no particular order, but I think what we've landed on is that it's a combination of trust and communication and closed loop communication. So it's not unidirectional, it's bidirectional, and it's closing the loop. We have to remember that public health has been doing health equity for a long time, not just recently. And so partnering with public health is a key thing. And I love, Belinda, that you have 2 folks with a master's in public health. So way to go, you're already there. That we have to remind ourselves that equity is not just 1 or 2 facets. It's not just race or ethnicity. It's age, something that may not be rare for older folks, could very well be rare and have a differential in lived experience for someone in the pediatric or the young adult population. Community partnerships are incredibly important. Social workers, I love that you lifted up social workers. I'm a big fan of them too. They bring empathy and understanding. They see the whole person's lived experience, not just the medicalized part of them. And qualitative information, that's incredibly important, and that we shouldn't be shy to use AI and maybe some fill in the blanks approaches. I learned the new term imputed data today. I love learning new things, but that we have to be careful about doing those things, right? We can't just throw it all into the machine and have it spit something out. We have to make sure that we're ensuring that it's capturing and conveying what we need. So with that, this is going to be our rapid fire round. One thing in the next year that IVI could do to make progress in health equity. So Anton, you want to give IVI a recommendation for an action item?
Yeah, just more of this convenings.
Great. Linda.
I would love to see a report on how to interact with patient advocacy groups, some tips on how to actually reach out. And it's not, there's some research on the researcher's side to who they're going to communicate, and not just assume you can just reach out and get what you want.
Okay. Sneha.
I would actually love to see fewer patient advocacy groups, more patients, because I even don't think that all patient advocacy groups, even we cannot claim to represent all young adult patients. We need individual patients, as I think an individual alluded to so perfectly. I think a lot of times we come with our preconceived biases of how things should be, and inherently they will trickle down to our patient community. And so I think finding those patients, it's not hard. Social media, I mean, we do everything is grassroots. Like, you all won't believe how grassroots we are as an organization. Others are too. So I think I'd love to see more individual patients engaged, and those who have not had opportunities to articulate things in the way that we want them to.
Wonderful. Great. Thank you so much. Please join me in thanking our three panelists. Yep.